Well, I think we're gonna make a start. Thank you very much for joining us. As you know, including by myself, there's a lot of talk about ultra-wide field imaging, and there's no way that we all need ultra-wide field imaging. We need ultra-wide field imaging, navigated ultra-wide field imaging now in 2026. We're almost there, and there's no doubt we need navigated peripheral OCT, but we still need indirect ophthalmoscopy with scleral depression. There's no way around it. I started ophthalmology. I know my son tells me you're starting to sound like a repetitive old man, but indirect ophthalmology was around when I started in 1990. It's still here, and it's still here to stay, because until today, there's no other way of visualizing the ora serrata in the way we can visualize it with indirect ophthalmoscopy. Also, if you want to treat the peripheral retina with laser, you need to have the skill to do indirect ophthalmoscopy, and we'll show you why. So these are my commercial disclosures. As you can see, a lot of imaging companies are there. Now, we talk about retinal examination, but the reality is when people are having a retinal examination, most people are being examined with a 78 or an ultra-wide field, non-contact lens, a wide field, but none of these lenses, unless you are at the booth of one of the lenses companies, allows you to see, unless you're doing it in a dummy eye, you don't normally see the ora serrata. Yes, you may see it in a high myope with a posterior insertion of the ora serrata, but normally you don't. So this is not a cartoon. This is an Optos RGB ora serrata. You can see the vitreous base, but we cannot access the ora serrata like this in every patient so reliably. And there are lesions that we definitely need to be able to diagnose, like a retinal tear, a retinal hole, lattice degeneration. So ophthalmoscopy goes a long way. It was von Helmholtz in 1850 that described the direct ophthalmoscope. Of course, we don't use a direct ophthalmoscope any longer. Charles Keppens created in 1945 the first headset binocular indirect. And it was Richard Killer who, and Killer and Norlace are sponsoring this symposium, is the one who developed the modern indirect ophthalmoscope. Now, I want to draw your attention to this. These are the AAO preferred practice patterns, but bear in mind that these are from 2019, and we are almost in 2026. So we can discuss this later. But in the preferred practice patterns, you can see, look at this, examination of peripheral fundus using scleral depression. This is part of the key elements. And this is the preferred method of evaluating peripheral vitreoretinal pathology. And as you can see, it's there. So we have to know indirect ophthalmoscopy. Now, there is a skill to this, and there is a learning. We have to remember that the image is going to be virtual. The image is going to be in front of the lens. You have to coordinate the head with your hand, and the image is going to be inverted and reversed, okay? Now, let me share with you this video. It has audio. Can you make it loud? Can you put it louder, please? A cradle that itself is wall mounted. So this is my office. And it charges the battery pack at the back of the scope. There are a series of filters, blue, white, red-free, and polarized. I tend to use the white light. You can also change the diameter of the light beam from a very small beam. For example, if you are doing indirect ophthalmoscopy through a small pupil, to a large beam. I tend to use the large beam. You can modify the intensity of the light, of course. You don't want to start with intense light, otherwise it's very uncomfortable for the patient. You start halfway through, and then if you need, you move up with intensity. You can change the length of the straps, of course, and you can modify the interpupillary distance. Okay, so I mount the scope on my head, I adjust the back strap and then the top strap, so it's securely positioned and it doesn't wobble on my head. Then I modify and adjust the interpupillary distance, I turn it on, and then I modify the height of the beam so that it is at the right angle, at the right distance from the patient. And here we go. So this is a very straightforward process, and you don't need to do this every day, every time. That's my office. I have a couch because almost every patient, if not every patient that comes to see me, undergoes indirect ophthalmoscopy with indentation. You can see here the indirect ophthalmoscope. So I stretch my arm when I'm sitting at the desk. I grab the indirect, and I do indirect ophthalmoscopy. And this is the indirect laser, which I'm going to discuss later. Because this is the one I use, I'm the only one using this one in my office, then I don't need to do this every time. This is set to the size of my head, a big head, as you can see, and the interpupillary distance, and it takes 2 seconds. The only thing that I need to readjust is the height of the light, because that will depend on what distance I'm examining a patient. But it's important that the indirect, this is fixed, there's a cradle fixed on the wall, and I just rest it, and the indirect charges, and it's important that it is at a comfortable distance, so you can use it. Now, there are different lenses that you can use. Some people still use the 20 diopter lens. I stopped using the 20 diopter lens in 1993 when I started my fellowship with Harvey Linkoff. And I use the 2.2 lens. Why do I use a 2.2 lens? Because it combines the magnification of a 20 diopter lens with the field of view of the 25 diopter lens. So I highly recommend using a 2.2 lens. Now let me show you the technique, one of the first video on the technique of scleral indentation. So it's important to explain to the patient in advance what you're going to do. Otherwise, the patient will go tense, the eyelids will go hard, and the patient will suffer, will be uncomfortable. And this is what happens. Most of us don't realize that if you have a relaxed patient, this is very straightforward, and it should last 1 minute per eye, as I'll show you in a couple of minutes. Let me show you the technique. Can you make the sound louder, please? So here I'm using a killer ophthalmoscope that has the capability of video recording. So of course the first thing is to mount the this is an indirect ophthalmoscope which has video capacity. So I can show you what I am seeing. Securing, tightening the straps, adjusting the interpupillary distance and the height of... So because this was in a suitcase, I had to readjust everything. And here you go, that's the 2.2 lens. A Volk 2.2 lens, and the Shocket scleral depressor. Some people use a thimble. I prefer, for me it's more comfortable, the Shocket depressor. Explain to the patient clearly what we're going to do, clear instructions, short, clear instructions. So it's easier with the patient in a supine position, then the patient is completely relaxed. You can do it with the patient sitting on the examination chair, but this is far more comfortable for the patient. The more you look to where I'm pressing, the less you will feel the pressure. Please remember. So that's essential, to ask the patient to look towards you are pressing. And remind the patient that you are pressing on the skin of the eyelids and not on the eye. Remember, patients are afraid. What is he going to do? He's going to press on my eye. No, we are not pressing on the eye. And start with low light. Ready? If you have any discomfort. I always start with the left eye, don't ask me why, and I go clockwise. And let me show you what I actually see. Let me show you the technique. So this is the 2.2 lens, and that's the Shocket depressor. So here you can see how I'm doing the indentation. Look, 2 seconds. I ended up straight on the aura. That's not edited. That's real time. You see, all you need to do is you place the indentor, you ask the patient to look up, and the space the space that the indentor occupies, that's enough to cause the indent. You don't really need to press. And you saw it. 2 seconds, I'm directly over the aura. And here we go again, the other eye. There's less skin when we do the 6 o'clock, but as you could see, I'm not pressing, and I'm there directly, right on the, look, there it is, the aura. I'm right at the aura. And you have to play with that reflex. You coordinate your hand with the head. And there again. So I ask the patient to look up and left, up and right, down and left, down and right. 1 minute per eye. That's it. I've examined the retina up to the aura, 360 degrees. Every patient with an acute PVD should undergo this because this is the only way to rule out retinal tears with 100% certainty.
You don't want to go there.
And look at this, because this is important.
There. You want to go there.
You want to press on the edge of the cartilage. You don't want to press too deep because that's painful. You don't want to press too close to the eyelid margin. You want to press on the posterior edge of the cartilage. Okay? So that's exactly how I see it. And you saw that's not edited. And I end up, look, I end up directly at the aura.
Directly over the aura. I'm falling directly over the aura.
And the patient doesn't even move. The patient doesn't have pain. You see? That's the aura.
Look down.
I end up directly at the aura. So, of course, I use OCT. Of course, I use ultra-wide field imaging. I started doing OCT, introduced OCT in the UK in 1998, time domain, and we published 3D rendering of the peripheral retina. This is the Optos device that I use every day with every patient, with navigated OCT, but I still do indirect ophthalmoscopy. And here you can see a retinal hole in the very periphery, and you can see cross-sectional OCT of that retinal hole, and this is how you see that same retinal hole with indirect ophthalmoscopy. You can see the difference. So you still need indirect ophthalmoscopy. Don't get me wrong, I cannot imagine my clinic without all of this imaging technology, but I cannot also imagine my clinic without indirect ophthalmoscopy. This is essential, 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 essential. You can see the hole there. And look, how easy it is. That's not edited, okay? So very straightforward. Let me show you some examples. This is an example of peripheral retinal hole. I still use indirect ophthalmoscopy, indirect ultra-wide field imaging, but I still do indirect ophthalmoscopy as I've just shown you. Now, why is it also important to know how to do indirect ophthalmoscopy? Because we want to be able to do indirect laser. How many of you do how do you treat a peripheral tear? I just need one answer. Laser, very good. But how do you do the laser? What technique do you use? There's no right or wrong, but just tell me what you do. Okay, say it in whatever language. Okay, do you use a contact lens? Okay, perfect. You use a contact lens. How many of you use a contact lens? 92.3%, okay. What contact lens do you use? A 3-mirror. Okay, so that's 94.6% of you using it. I'm very good at maths. That's why I'm a retina surgeon, of course. I have not used a contact lens for over 20 years. And if I use a contact lens, I use a Mainster 165. Now, I don't have any commercial association, unfortunately, with the Mainster 165. I wish I did. But the reason why I use a Mainster 165 is because I don't have the mirrors. I know it's an inverted and reversed image. So there's no way of getting confused with the mirrors. And peripheral lesions, I do indirect laser. Much easier. Patient comes with a tear, acute PVD. I ask the patient to lie on supine position on that couch. I do indirect ophthalmoscopy, and I just say, well, you've got a tear. We'll go through a consent, the cost, of course, all of this stuff we need to do. And I just grab the other one, the Norlace system, which I'll describe in a minute, and then I just put it on, same lens, same scale depressor, and I do laser. That's it, 5 minutes. You feel guilty about charging for it. So I never feel guilty, but in any case. So Norlace. So we started with a single spot indirect laser. And as you know, the Norlace is sponsoring this event, as you know, with Killer, and I'm a consultant for Norlace. It's a self-contained laser, but the beauty of it is that all the laser source is within the headset. So you've got the headset, a pedal, and this tablet, and you can also talk to the tablet. The tablet can increase or decrease the power, duration with voice command. And nowadays, I've moved to the Lynx, which is a pattern indirect ophthalmoscope. Like Pascal, you may remember my presentations. I did a lot of research in Pascal and laser, and now I've moved to Lynx, so you can do 2x2s, 5x5 patterns with the same Lynx. You can also do single spot. And this is what the scope looks on my head, of course. So let's look at some examples. This is a patient that came from a neighboring clinic, seen by a VR surgeon, treated with a contact lens, and what was treated was the posterior edge of the retinal tear. Because with a contact lens, it's very difficult to reach, or impossible to reach, the anterior edge of most lesions. And it's the anterior edge that's the most important, because fluid doesn't start moving under the retina through the posterior edge of the tear. It's under the horns and under the flap. So it's the horns and the flap what's most important to treat. So when people come with the posterior edge treated, you know that they've done a contact lens, and really, please move to indirect laser, because your life will be easier and it will be better for patients. And this is the end result. You can see there, straight after the laser, how I've completed the treatment all around the anterior edge. This is another example. This is straight after the laser. You can see the type of pattern that I do, and this is a month later. You can see that I've gone all around the tear. It's a large tear before, straight after the laser, and a month later you can see the pigmentation. You don't want too confluent laser. You don't want laser that's too white. Remember that you apply the laser spots, and an hour later the laser spots will appear even whiter because inflammation sets in. So if you already start with a very white spot, you are going to end up perhaps cutting the retina rather than welding the retina. And here are my settings. For retinopexy, I use 200 millisecond duration. And I start with 80 milliwatts, and I go up until I get the desired intensity of spot. Here you can see, this is a nice example of why we need indirect ophthalmoscopy. Look, this is navigated ultra-wide field imaging. You can see how peripheral we've gone with the ultra-wide imaging, but look at what we can see with indirect ophthalmoscope. Look how easy it is. I just place the indentor there, lens in front of the eye, massage a little bit so I go a bit further posterior, and I move the indentor anterior and posteriorly so I can see the retina at an angle, and you can see here the flap. You will see the flap of the tear standing up, and you can see how I've lasered all around. And this is easier for the patient. A drop of topical anesthesia, there's no gunky stuff, nothing, no contact lens, no red eye. They can even wear a contact lens straight after. Very, very, very straightforward. This is a patient where I did surgery. Surgery didn't work, had 2 vitrectomies, and an edge still opened up, and I created a barrage of laser. There's still gas in the eye, But you can see here the reflection, how I've managed, on the reflection, you can see how I've managed to laser up to the aura, because that's where it's important. It's important to create a barrage up to the aura. But the only way to reach that area was with the indirect ophthalmoscope. So if you don't do indirect ophthalmoscopy, you're really limiting yourself. This is a patient with a high myop, with lattice, an area of lattice, but look at navigated OCT. Look how elevated this area is, and look at the tears in lattice. And this is a patient, this is a Russian model that wanted to have ICL to get rid of the myopia, to correct the myopia, and she didn't want laser straight away. We followed it up, and then we could show that this was progressing. Then she accepted the laser, and here you can see how I've surrounded the whole area of lattice with tears. You don't treat the tears, you surround the whole area of lattice. This is another example. Look, this is even a subclinical retinal detachment. There's a large tear there, subclinical retinal detachment. This was asymptomatic. The patient was not symptomatic of loss of vision. Once the patient is symptomatic of loss of vision, I don't even think about doing laser. I think about a vitrectomy surgery, of course. But this patient did not want surgery, wanted to, I thought, well, look, this is superior, there's already a lot of fluid, it may not work, but it did work. This is a patient with, this is somebody, the husband of somebody who was working at our clinic, and you can see here an area of lattice, you can see the elevation, you can see there's a large hole in lattice, you can see it very clearly here, and I surrounded the whole area. Even though this is inferior, my threshold for laser was very, very low, because done correctly, there's very low risk of complications with laser. This is a patient that has peripheral retinoschisis with retinal detachment. So this is schisis, and this area here is retinal detachment. So we do not treat retinoschisis, because you are creating an addition between the outer retina and the RPE, but the schisis goes above the outer retina, so you don't achieve anything. But the reason why I decided to treat was because this is detachment. So I surrounded the detachment, and as you can see, the laser goes around the detachment, and here it doesn't reach the aura, okay? That's the little hole. And another example, it would be very difficult to treat this round hole with fluid and traction with a contact lens. Another example of peripheral retinal tears and the type of laser that I do and the settings, 200 milliwatts. Other examples of treatment, so you can see the type of treatment that I do and how it looks a month later. Lattice degeneration with a retinal hole, and you can see how I surround the whole area of lattice, and you can see the you can get rid of that alarm because I'm the only speaker. And you can see the area of pigmentation. Here you can see again that example that I showed you before. And look at this. This is, you can see how the before and after of the same lesion. You can see how easy it is to see this with indirect ophthalmoscope, and how I've managed to laser completely 360-degree the lesion all around it. Very, very, very straightforward. And this is myself doing the laser, of course. Again, another example. This is a large tear along all of the area of lattice. Here you can see how I've done the laser, and I've lasered other very small tears here. And you can miss these tears, because these are very small tears, and the way you identify them is when you are indenting, you see the flap raising up. And so that's why it is such a good diagnostic technology. This is an example I'm very proud of. This is a diabetic patient. You can see the shadow of the YAG laser posterior capsulotomy, pseudophakic diabetic patient that had very, very florid neovascularization at the disc. I've done panretinal photocoagulation, but I don't go for very hard, very strong panretinal photocoagulation because I don't want to reduce the visual field of a patient. I am a believer in targeted retinal photocoagulation, so I do the retinal laser guided by ultra-wide-field fundus fluorescein angiography or ultra-wide-field OCT angiography. And the only way to treat this peripheral retina, so peripheral, was with indirect laser. So here you can see before, and these are the areas that I've treated. This is the fluorescein angiogram, and you can see the resolution of the neovascularization at the disc, and this patient has remained free of treatment for over a year. And look at the difference between the right eye that was treated elsewhere and the left eye, which is the eye that I treated. You can see on fundus autofluorescence that the right eye has significant more carbonization of the retina, and therefore this patient has lost significant visual field in the right eye. And there's no need for that, because most people are treating the mid-periphery and forgetting to treat the peripheral retina in a diabetic. And it's important to do this. It's important for these patients to undergo ultra-wide-field fundus fluorescein angiography, and the way to reach the peripheral retina, the best way is to do indirect laser. This is a patient with juvenile rheumatoid arthritis, and again, much easier to reach the peripheral areas of telangiectatic changes and microaneurysms with indirect laser. And we published a paper in 2001 doing the same thing in Coats disease. The paper is in Retina. So you can see the before and after. You can see how the serous detachment has flattened after doing peripheral targeted laser photocoagulation. So in conclusion, dilated slit lamp examination is not enough. Every day we see at our institute patients that come for a second opinion having had a PVD, and how were they examined? At the slit lamp with a handheld lens. Well, that's the same as going to the optician. They don't need to go to the ophthalmologist if you do the same thing. Now, as I said, most examinations include just slit lamp power microscopy, and we can't miss pathology like that. We really need to do indirect ophthalmoscopy. It's the only way to see the retina up to the ora serrata. I'm sure technology will change, but at the moment there's no other way. So indirect ophthalmoscopy with indentation is still an essential skill. And indirect laser, in my opinion, is the best way to treat peripheral lesions. I don't work alone. I'm supported by a large team, and thank you very much to all of you and to the team, and Norlace, and Killer, Nicola, Catherine, Graham. Thank you very much for all the support. And we are very privileged to have Paul Runge here, who will also provide an opinion. He's an expert in ROP. He travels to very distant parts of the world to treat babies with ROP, amongst others, so we want to hear his opinion as well.
Thank you very much, Paulo.